All right, guys. We've been playing a lot of things right now and doing a lot of things, and then what we realize, we don't even have anybody viewing this right now, so it's okay. What we realized is that I had never started a podcast. So let's try this again.
This is a demonstration of
Welcome. My name is Vincent Bird, Associate Professor of Urology at the University of Florida College of Medicine, Department of Urology. Let's talk about what's new in kidney cancer research and treatment. Let's begin this discussion by talking about what is kidney cancer. Kidney cancer forms in the tissues of the kidneys. There are different types. The most common type is renal cell carcinoma. This cancer forms in the lining of small tubes in the kidney that filter blood and remove waste products. Less common forms of kidney cancer are renal pelvis carcinoma, which essentially is a cancer that forms on the urinary lining inside the kidney. A third type is Wilms tumor, which is a kidney cancer that usually develops in children under the age of 5. Let's take a look at some facts about kidney cancer. The National Institute of Health keeps high-quality data regarding the incidence of cancer in our country. As we can see from this list, kidney and renal pelvis cancer are certainly a highly prevalent cancer. Furthermore, the proportion of patients dying from this cancer is significant, which clearly shows that further efforts are needed to be dedicated in treating this disease. As we can see depicted here, it is estimated that there will be almost 64,000 new cases of kidney cancer in 2014, with the number of deaths being relatively stable. The most common type of kidney cancer, as we mentioned previously, is renal cell carcinoma, which will be the further focus of this discussion. For patients with this disease, 30% of them will have metastasis at time of diagnosis. Another 30% will develop metastasis sometime after their diagnosis and potential treatment. Furthermore, renal...
Okay, people are watching, sorry.
As we can see depicted here, it is estimated that there will be almost 64,000 new cases of kidney cancer in 2014, with the number of deaths being relatively stable. The most common type of kidney cancer, as we mentioned previously, is renal cell carcinoma, which will be the further focus of this discussion. For patients with this disease,
What?
He's got a stent. Who's the guy with the tumor? Gary Rush. He's the guy with the renal tumor that I didn't know for 8 months. So it's an infection. That's it. Ironic was really good. So.
Hey, Sigil, so the problem is that I don't know how to SharePoint this PowerPoint. Like, how does it... I guess we will share the desktop, start the screen share, but then it just goes crazy. It's going crazy on me. This, what is it doing? Okay, guys, so Matt, what's up? Yeah, 290. We took 295. Okay, all right. Okay, bye.
Bluebird was on the previous server, right?
Yeah, but I was just playing it.
How about the ones that are on this server?
I'm trying to call right now. Dude, you're killing me. Hey, Alan. Hey, man. I'm sorry. We're having some technical difficulties. I just sent you a new link. If you click on it, you'll join the Hangout. Thank you, man. Sorry. Right now, when you log on, I'm gonna stay on the. Okay. Okay. Alan here. Novel treatments for large prostate. We're okay, man. We're running on time with these things. I mean,
Yeah.
just having some.
And even the time, like, we won't be that. I think I had planned for a lot of extra time for the segment, you know. So I've buffered it in. Like, still only be like half an hour. Should I follow this truck? You think it makes a big difference? Or? I don't think so, right? 'Cause it's like,
Oh, you know what those guys did? They're Jacksonville because Rob's picking up his friend.
yeah. But the thing is that that's probably where the accident is, right?
Yeah, so we're
So I
gonna.
think that's why we did this.
No, I think unless you. I mean,
This new upgrade that just happened to route you away from.
yeah. Here he goes. Hey, Alan, how are you doing, man? Suju is the ever optimist, and I am the ever realist.
Can you hear me?
So I'm going to be reading some text messages I'm getting while I'm waiting for our speakers to log on. Someone is watching our live. Are you watching our live feed right now?
Yeah, I need it. Yeah. Is there a
Okay.
delay? Yeah.
Good.
Hey.
Hey, Alan, how are you, bro?
Good. What's going on, CO?
Okay. We have
things are going
traffic
well.
update.
I'm gonna drive in, and it's crazy, but it's awesome. It's turning out pretty cool. So thank you so much for your patience, man. Sorry to keep you waiting.
How many people driving with you guys?
We
How many
have
cars?
3 cars altogether now, 7, right?
We have 6 Teslas, and
6
we got 3 support vehicles. We got
About
nine cars.
altogether. So it was
Nice.
really cool. We had about 200-300 people in Claremont to send us off, and then and we've had a pretty good turnout at each of the other stops too. So we just met up with Dr. Ali Kazryan and Greg Broderick over in St. Augustine.
Nice.
So Dr. Nieder, you were going to talk about enlarged prostate, I think.
Oh no, blood.
We changed it. We were going to do hematuria and bladder cancer.
Yep.
All right, let's talk about that. I was just going to say, let's talk about something else. I think we've talked a lot about prostate this morning.
So we're gonna do blood. And
So please tell us, in our audience, if we have men that come in with blood in their urine, or sometimes I get a lot of patients that have microscopic. On lab work they've done, they find blood. And Dr. Nieder, thank you so much for talking to us this morning.
Good. Can you guys see my slides?
Yeah, we can see them fresh and clear.
All right, good. So, yeah, I mean, briefly, I thought we'd just talk about bladder cancer and blood in the urine. As you guys know, you guys probably see a lot of patients, too, who get referred for blood in the urine to your office, though not too often do they actually have bladder tumors. The flip side, of course, is that you probably also see a decent number of patients who present with big bladder tumors who've had blood in their urine for years or months and have been treated with multiple courses and rounds of antibiotics, and no one actually thought to work it up for bladder cancer. So it's probably not an uncommon event for urologists, unfortunately. You guys can hear me?
We can hear you. I just muted ourselves, so you can't hear us.
Okay, gotcha. All right, perfect. So just some basic statistics. Bladder cancer, 4th most common most common cancer in men in the U.S., 9th for women. You know, over 60,000 cases a year and 12,000 deaths. This is unfortunately can be a lethal cancer. The risk factors, which you guys obviously know, smoking, heavily related to bladder cancer, and chemical exposure, the 2 main risk factors. So typical signs and symptoms of bladder cancer, you see blood in the urine, which we call hematuria, really the most common sign of bladder cancer, and it can be either microscopic or gross, meaning that even if you have just some small red cells in your urine that your doctor tells you about, that could be a significant sign, or if you actually see your urine's red. Burning in the urine, dysuria, frequency and urgency, feeling like you need to go to the bathroom a lot, or if you actually have abdominal pain or kidney pain, all can be signs. So the key thing, and I think the real take-home message, is that you really need to rule out, with blood in the urine, more insidious problems. So you can't just assume it's secondary to your urinary tract infection, kidney stones, an enlarged prostate, or renal cysts. And most patients, if they have risk factors for bladder cancer, which typically age over 40, people who are smokers, they really need a workup with a CAT scan, urine tests, and a cystoscopy, which is typically only performed by urologists. So we've done a couple papers just looking at some of the basic information. This was back in 2006. We surveyed patients regarding their knowledge regarding risk factors for bladder cancer. You know, it's sort of intuitive, but you know, everybody, 98% at least, knew that tobacco was a risk factor for lung cancer, but really only about a third of the people knew it was a risk factor for bladder cancer. And you know, our conclusion was that we really need to improve education to prevent smoking-related cancers. We did another survey a couple of years after that where we surveyed primary care physicians and gynecologists regarding what's their typical evaluation of hematuria. And what we found was that only 14% and 64% of patients who had either microscopic or gross hematuria were automatically referred to urology. And so, you know, we sort of concluded the take-home message was that there's probably a lot of patients being treated for a lot of other problems, such as UTIs, and aren't getting appropriately worked up, and could be having other, you know, problems like bladder cancer. So, at the end of the day, the real question is how do we improve outcomes? You need to reduce tobacco use, obviously. You need to educate patients that hematuria can be a sign of bladder cancer, and especially for people with risk factors, they need to be aware of that. You know, so that means smokers. And patients with hematuria really need to be evaluated in a timely fashion to prevent a delay in diagnosis. So, you know, that's really the bottom line. Hematuria can be a significant finding. Tobacco is a risk factor, I think the take-home message. And all patients with hematuria really need a thorough evaluation because at the end of the day, early diagnosis is key. Thanks, guys.
No, that was great. Thank you very much for that that presentation. Now, sometimes we have patients that come in with blood in their semen. So, can you tell us a little bit about that? Like, is that a huge risk factor for cancer as well?
So it tends not to be. I mean, my typical workup for guys with hematospermia or blood in the semen is I usually just check, first of all, make sure they really don't have blood in the urine. So we have a lot of patients with incidental, essentially, hematospermia. So their urinalysis is normal. They've never had any signs or symptoms of bladder tumor. I usually check a cytology to make sure there's no cancer cells in the urine, and I'll check a PSA too to make sure there's nothing you know, too wrong with the prostate. For a lot of patients, this is pretty self-limited.
Now, as we're driving, we're actually driving to Savannah. We got about 2 hours to go, 135 miles. Anything you want to say to our audience about why do men need to take better care of themselves?
Yeah, I mean, clearly this is you know, I think a lot of medical problems, at least for older men, could clearly be ameliorated with just you know, healthy living, diet, nutrition, exercise. You know, we want to prevent guys from showing up too late when there's too many problems. A lot of, you know, proactive screening really probably goes a long way.
Well, thank you very much, and we appreciate it, and I hope you can continue to follow us on our drive at driveformenshealth.com. Or you know, socializing with us on our Twitter, Facebook, Instagram feeds. Thank you so much, and we look forward to seeing you, you know, outside of the drive, but next year when we drive to California. Thank you so much.
All right, safe travels, guys. Bye.
Thanks, and go blue, man. So
Go blue.
we had
There
the
you go, blue.
Central Florida Club out there to send us off, and we got the little M logo on the car too, man.
Look at this. Just for you. There you go.
You said it, bro. You said, okay, go blue, bro.
You just signed off. Thanks for you guys. Sinai Medical at Columbia University in Miami.
Awesome.
Show this. so inefficient.
Yeah.
I'm so inefficient like this. That's okay. Next year we'll get.
Next year we'll get it.
Maybe Google will follow us. You know.
It's true.
But I think we'll get better at it.
Yeah. I think if it's all pre-recorded, if it's all loaded on YouTube, right? Then you can just click on it, right? If it goes on a channel, right? Can you release it then or something?
What? Yeah, it's live right now. They're all up there right now. Everything we've been doing this morning is up there.
That's awesome.
And I got a message saying everyone can hear the thing you're saying when you're trying to say you're not saying. Oops. Hey boss, this is Jamin. How you doing, man? Hey, listen, I think I sent you like 3 links. Please follow the last link I sent you, because every time AT&T screws us, I have to send you a new link. So sorry about that. Yeah, you're ready, boss. We're ready for you. You are on schedule. We're not on schedule. All right. I just got a text message saying, I can see your nose hairs. Thank you so much for that comment. Don't comment on anything educational. So I'm going to show you what we see right now. Now, guys, should I tell them about the Google Glass?
Yeah.
So we have Google Glasses. We bought them for this event, but Google Glasses were very buggy, and they basically died on me, and I've been back and forth with support, and they really were not able to support me early enough for this drive. So next year we're probably going to have to find a newer technology or something. But you guys, you know, you don't need to be the glass. You can just see what we're doing. I'm going to put you right up here for a few minutes.
It's beautiful.
And you can look outside the road. So
we're driving on.
It's a very exciting road.
It's 295, right?
We're on 295. We're looping around Jacksonville.
Heading to the north side.
There's some workers ahead.
There's an accident in Jacksonville, 95, so we're avoiding that.
Wasn't us.
But we were able to avoid that traffic delay, so
Yep.
we're actually making up some time. We're going to be only half an hour behind schedule.
Well, that's what Sidjo says now. I'm going to put you right up here for a few minutes. Hey, how are you? Hey, man. Hey, turn off the road. Hey, turn off the road. Very exciting road.
It's 295.
We're on 295. We're looping around Jacksonville.
There's the north side.
There's some workers ahead.
There's an accident.
Akshay?
Hey, can you see me?
Yeah, we can hear you, but can you turn off the YouTube live stream you're watching? Yep.
Oh, one sec.
Making up some time. We're going to be only half an hour behind schedule.
Well, that's what Sidjo says now. And you have a lot of light behind you, so we can't see your beautiful face.
Is that better?
Yeah. Is there any way you can sit where the light is facing you? Because we can't see your face, and we want all the audience to see how amazing you are. All right, there you go.
The audience would be more interested in.
Hey, bro, how are you, man?
Hey, how are you? How's it going?
Oh,
Good.
It's really amazing, dude. It's really amazing.
So Dr. Akshay Bandari is, once again, as I mentioned earlier, Director of Robotic Urology and Assistant Professor of Clinical Urology at Mount Sinai Medical Center and Columbia University in Miami, Florida. And today he's going to be talking to us about robotics in prostate and kidney cancer. Now, Dr. Bandari, you are our first speaker about robotics, so maybe you can talk a little bit about what exactly robotic surgery is. Is a robot actually going to be doing my surgery? And number two, segueing into how the robot is used.
Perfect. You know, I actually had the right slides for that. Can you see my slides now or no?
No, you have to share your slides, so there's a little tab
I
on
thought
the
I thought I was. Let me do it again because I try to screen share, right? For whatever reason. Trying to hit screen share and it's not letting me.
Little green button kind of on the side.
Yeah, no, I see that. I believe me. Let me see. Maybe there's. Oh, there you go.
Now, does this ever happen when with the robot?
Can you see it?
Yeah,
Now
we can see it. We can see it.
We can see it.
You get it? The first slide?
Oh, beautiful, beautiful, beautiful. All right, Dr. Bandari, thank you.
All right, there you go. So just basics about robotics, like you said, you know, it's a teleoperated system It's got a stereoscopic 3D vision, and it works on what's called a master-slave system, where the surgeon sits on a console and makes certain movements that get translated into equally precise movements within the patient's body. So none of this is pre-programmed. It's not like the robot has a mind of its own. It's just following what the surgeon does. Just to get an idea, it's got basically three components. There's a console on which the surgeon sits. There's a patient side cart, which is what is attached to the patient. And then there is the vision cart that helps process the vision from the very superior 3D camera into what's being televised into the console, where the surgeon has a feeling of immersion, wherein you just feel like you're within the body. So the highlights of a robotic system are it gives you a 10 times magnification. It's a high definition 3D vision. The movements the instruments are wristed, so it gives you multiple degrees of freedom, unlike standard laparoscopy, where it's rigid instruments and it's very difficult to sew and do very accurate tasks. And it filters any tremor that the surgeon might have, and it does scale down your motion, which again accounts for improved accuracy. So the advantages of robotic surgery are mostly all the advantages of anything minimally invasive, but it is also precise, and obviously that translates to less blood loss, shorter hospital stay, and better recovery. The applications of robotic surgery for urology are many, but the most common application is obviously for prostatectomy, kidney cancer, bladder cancer, reconstructive procedures, as well as it's used for female pelvic wall prolapse, and obviously it's used for what Dr. Parakeetal and Dr. Brumbutt do, which they'll probably talk more about. So with regards to prostatectomy, this is the most common robotic urologic procedure done. And obviously, the biggest benefit is it's done with smaller incisions compared to the big incision that used to be done before. But not only that, it's much more precise. And in experienced hands, the results are much more superior than open prostatectomy. This was our publication where I trained at Henry Ford Hospital, where we looked at 3,300 patients approximately. And we concluded that it was a very safe procedure with very good outcomes. Once again, in experienced hands. The other increased application of robotic surgery is for partial nephrectomies, where if you're diagnosed with a mass on your kidney, unlike before where the whole kidney had to be removed and had to be done open, now for most renal tumors, we could save the kidney, just remove the tumor, and do it all minimally invasively, robotically, where patients can actually go home the next day. So instead of a big flank incision, you have 5 or 6 small incisions, and the recovery is much more rapid. For those who know someone who's been diagnosed with a renal mass, or if you were unfortunately diagnosed with one, it's very important because the treatment is changing. We are offering partial nephrectomy for even bigger tumors. And so if someone you know or a loved one has been diagnosed with kidney cancer, and has been recommended to get the kidney removed, it would be a good idea to have a second opinion with someone who does more of these. Make sure that you're not a candidate for what's called a partial nephrectomy. There's enough evidence that suggests you save the kidney versus remove one and leave the person with one kidney, your risk of having end-stage renal disease needing dialysis is much less. And the outcomes are actually very comparable in terms of cancer cure, even much more than that was one of the publications. So this is pretty much my presentation. I hope I'm still online because I'm not hearing anything. But if there's any questions, I am here.
That was great. So I heard there's a new robot out there. You think that's going to change anything, or?
Well, so there are certain good things about the new robot. It's called the XI, the prior version of the SI, as you know, and it's important it might be more helpful for multi-site surgery. So from a urologic perspective, we do a lot of nephrostomy. So you have to think about kidney, the ureter, and the top of the bladder. And we were able to do it with the standard robot without really around. Sometimes it does get challenging, and I see that might be some application that might be helpful for us. But I think more importantly, the new robot's probably going to help make it much more better.
Awesome. Well, Dr. Bhandari, anything you want to say out there to the general mass here about why they should take care of themselves better?
I mean, you guys are doing a phenomenal job. I think this is something going in line with what you guys have been trying to promote. When always, to go see a physician when in doubt. If you're a young guy, your risk of having testicular cancer is higher, and it's very important to be aware of testicular self-exams. If you're middle-aged and older, then obviously you're talking of screening for prostate cancer, screening for kidney cancer in terms of making sure you have urine analyses and all done. So again, men's health, it's important. We have to make sure we take it seriously.
Well, thank you so much for logging on with us today. Please follow us on our various social media feeds or go to our website, drive4menshealth.com. And thank you so much, and we look forward to talking to you outside of the drive, and look forward to having you participate, hopefully driving with us next year.
Absolutely. I see I'm missing all the fun. Guys, drive safe and have a good time.
Yeah, just block your schedule right now for next year, man. We're booking you right now. So.
You got it. Take care.
Thank you very much. Thank you. Thank you.
All right, bye.
Thanks, guys.
What the hell's going on here?
No copy. What's it saying?
It's just being retarded. So Dr. Pericottle didn't give me the presentations that he was doing beforehand. So I think would you do them like last night? Taking our time here, loading up the talk. But we're going to actually be talking about something very serious next, and I really feel strongly about this topic. We actually are.
Slides, right? Just like 4.
We can do it. And we're actually involved with our own hospital to help with prevention of this, and that is catheter-associated urinary tract infections. Now, you guys are probably thinking, what? But what a catheter is catheter, if you've ever had surgery or ever had a need for one, is basically something, it's tubing that they put into your bladder. It goes in through your penis or your urethra, and that is put there so you can drain your bladder. It's either put in because they need they need to measure how much urine you're putting out if you're really sick, or if you have issues where you can't empty your bladder, such as your prostate's too large, or your bladder has neurogenic bladder, meaning it's not able to pump out the urine like it should. So when this happens, one of the options is basically where you would have a catheter put inside of you. So Dr. Pericottle and I are going to be talking about catheters, and there is an issue with catheters, that is you can get certain urinary tract infections, meaning you can get infections of your basically your bladder when this is happening. So I'm going to share these slides with you guys, and then we're going to kind of talk about them here. So
this is I want to give credit to Dr. Errol Singh. He's kind of a pioneering urologist who's developed kind of a new visual Foley catheter system. So we'll talk a little bit about that. The whole idea is to minimize the trauma when a catheter is put in, and potentially really reduce those risk of infections and trauma and bleeding to the urethra. So James is going to kind of, he's kindly put together some slides for us, and we'll kind of go through them. So when you think about technology advancement, scary in that we still do a lot of things that we used to do, right? I mean, from the old ages in terms of putting catheters in, and Jamin will kind of go over some of the details. In terms
yes, you can see there's there's a lot of new technology. So if you look at how catheters were made, there were silver coil catheters, rubber catheters, Foley catheters. There's many different ways, and then eventually what happened in the late 90s is we got flexible cystoscopy, and we do a lot of flexible cystoscopy. What that basically is where people are we can have these catheters. We do a lot of these procedures. Earlier we talked about blood in the urine, and now this is something that's used to actually look inside the bladder to find the cause of the blood in the urine. And the thing is that flexible cystoscopy is generally done by a urologist, and it's procedure. So it's very difficult to always do flexible cystoscopy. So when we're putting in these catheters, why not have a way where we can actually see it as technology advanced? And what Percuvision did was they basically put a little camera, a fiber optic camera, into the catheter itself, so that you don't always have to do these flexible cystoscopies, and you can actually go in and with the camera and the catheter, you can kind of see what's going on inside. So there's been a lot of innovation with how catheters are made and how catheters are used now. So there's
this slide kind of talks about how some direct urinary catheterization. So the problem is that when you have trauma due to let's say there's a stricture or something in the urethra and you're trying to force the catheter in. If it causes damage to your urethra, breaks that lining, you can get bleeding. That infection then can lead to sepsis, urethritis, epidermitis, orchitis. Basically, these are just different types of infection in different areas of the urethral reproductive of the urinary system. And then you can also get really bad infections, something called Fournier's gangrene, where the infection gets into certain planes in the genital area. You can have an infection that spreads very rapidly that requires aggressive surgery and debridement. So these are, even though these are rare complications, really complications that we don't want a patient or a family member or any URI to go through. And so the question is, how do we really get into a mode where we prevent these infections or trauma right to begin with? And that's where this new treatment modality or option called direct vision comes into play. Jamie's going to continue that on the next slide.
So what it basically is, I talked about this earlier, is basically you have a little fiber optic.
It's a fiber optic Foley, and then this kind of shows you the different parts, and yeah, go ahead.
You have the catheter, you have the visual guide.
Sorry, our computer's running a little slow.
It's all right. Technical difficulties, not a problem. I think it's the way it's broadcasting that's the issue.
Yeah. So we apologize. The clickers. Oh, there we go. You got it.
Okay.
So basically, this catheter includes it's like a regular Foley catheter, like a plastic tube, but it's got an additional port that allows a small fiber optic lens to go through. And this is what allows us to visually see what's going on. What's really neat is that through the main drainage port, you could put a little connector and put a guide wire through it. So instead of having to do a formal cystoscopy where sometimes you have to give sedation, the patient will be more uncomfortable for the patient. Just by the bedside, we can use this visual Foley catheter to kind of avoid little nooks or strictures in the urethra and not push aggressively. So if you see something like this, you can kind of curve or rotate the catheter so that you could get a small catheter in to drain the bladder without causing trauma or any bleeding or damage to the system. And so this system is called the direct vision system. If you guys have the opportunity to come out to New York tomorrow morning, we'll have it on display at the Tesla showroom in the morning as well. And so, really neat device, and I think it's really going to dramatically improve the quality of care we can give. What's really neat about this technology too is that it could be set up for telesurgery or telemonitoring capabilities. So ideally, you can think of this being used. It would come in a small suitcase-like device that you can open up, and you could have a technician somewhere in a remote village or somewhere that's far away from a doctor, and actually have the doctor visually seeing this remotely. What we're hoping will happen over time is hospitals itself put the full, technicians, and as soon as they have any difficulty, they could call the physician up and actually just through your iPhone or portable device actually show the images of what's going on in the urethra, so that we'd be much less likely to cause trauma or bleeding and actually see what's going on. So if we could tell the nurse, hey, one minute back off, and I'll be right in, and we'll put the catheter in. So we're really hoping that this will really dramatically change the way that we can deliver care, and also allow the nurse catheter in safely with zero risk of damage or trauma. So Jamin, you can see the next slide. And so the last slide pretty much just shows an image. On the right-hand side, what you're looking at is an image where there's a tight stricture or so. And what we're doing basically is using a guide wire through the main port that usually drains the urine to get the wire in the right spot. And then you can kind of feed the catheter over the wire into the bladder. And so this would be a temporizing measure. And then obviously the urologist could come in later. Later point we could take the patient to the OR if they need any surgical correction of that stricture. But what's amazing is that we're able to catheterize this patient then bedside without causing any bleeding or trauma or creating a lot of pain and grief for the patients. And so, I think putting a catheter in itself is an important part of the healthcare delivery system. And right now, we're routinely putting catheters in, but I think we can take our game to the next level and really minimize trauma and infections right from the core. So with that, I have to get back to driving. I'm going to let Jamin take over.
Yeah, thank you very much, Dr. Percotto. I think that's great. If you guys have any...
Again, we want to thank our sponsors. PercuVision is one of our sponsors, so I want to kindly thank them for their kind generosity. So please go on our website, www.driveformenshealth.com, and check out their blog and information, and we'll have links to their website. Please check out the product.
So about 109 miles. We get there at 3 p.m., which is, a half an hour behind schedule?
Yeah, we're supposed to get there at 2:25, so not too bad.
Oh, 2:25, so we're a little behind schedule, but not a problem.
We were about an hour behind when we started, so things, luckily, I put in a little extra time, thankfully, hopefully.
Oh, okay, so now Dr. Mendenhall is waiting. I think it's him next. I think it's him. Let me check the schedule, guys. I have it right here, bro. I have it. I'm going to send him a new link. Dr. Mendenhall, if you are watching, I'm going to be sending you a new link here because we did lose connection. Thank you, AT&T. I think hopefully they'll sponsor us next year. Just a little plug in there. Let's see. Dr. Mendenhall is going to be joining us here in a few minutes. So I don't know if you can tell, but I'm getting a little tired here, so I think we got to play some Katy Perry after Dr. Mendenhall's talk here.
Yeah, maybe in between the next two talks.
Yeah, maybe we gotta play some music. We gotta
music.
And the
you
thing
guys
is,
are more than willing to listen, right?
And the thing is, I'm feeling a little dehydrated right now. But if I drink water, then I have to stop and go to the bathroom.
It's only an hour and a half. I mean, do you think your bladder can hang?
No, I'm okay right now. I don't really have to pee right now.
We do have these lovely Tesla mugs as an
yes.
emergency.
Oh yeah. So Tesla sent us these mugs here.
They're beautiful.
Tesla sent us a lot of stuff. And I think Elon is going to be chiming in at 8 p.m. tonight. So Elon Musk is going to be here at 8 p.m. tonight,
if you're
guys.
listening, Elon, we love you.
Yeah, no, he is. He's one of the viewers. It says right here, Elon Musk. But Elon, I think it's great. So, what should we ask Elon when he calls at 8 p.m.?
Yeah, what would you ask him?
What would I ask him? I would ask him, does he like New York pizza?
I guess so.
Because he's coming to New York tomorrow as well at 8 a.m. at the Tesla dealership when we get there. I think he's going to bring his buddy Matt Lauer and Gio Benitez. And I think they're going to be kind of live streaming because they are they're so healthy and great looking guys on TV.
Did you send that link to Dr. Mendenhall?
I did.
Okay,
Oh, sorry, I got caught up in.
Poor guy, man.
No, I did send the link. Let me call him. I should call him right too. Why do you gotta? I think that's code for get back to work. Stop. Let's see here, guys. Let's call Dr. Mendenhall before I get in trouble. 1503 740. Oh, I can't give away his number.
Thanks for just telling it the half of the world out there, Dr. Mendenhall's cell phone number.
Okay, let's see. Hey, boss, is it working? So did you click on that link? No, wait. Did you click on the link I just sent you, like 2 seconds ago? No. The link like 2 seconds ago. Yeah, because we lost. We're driving to a new separate link, so we have to start a new. Okay, here you go. Well, why don't you try? I just sent you another link. Try this one. Just click on the link, and then it should ask you to. Have you ever done Hangout with? But did you try it yesterday? I thought you said you're good to go, so that's why I figured. Yeah. No, it's okay. And you're on a computer, right? A laptop or a desktop? The subject is a lot of just different letters. And I'm going to send it. Did you click on that? You got this. There he goes.
Well, good afternoon, gentlemen. I hope you're having a safe drive.
We're trying. We're
We're in Georgia, headed close to, well, actually not too close, but we have about an hour and a half till we reach Savannah.
Well, very good, very good. I'll just dive in here. I've got about 3 to 4 minutes. Would you like me to just start?
Yeah,
Sure.
yeah. Dr. Mendenhall is medical director of Hazelden in Beaverton, Hazelden Betty Ford Foundation in Oregon.
That's
so
great. Well,
renowned pain management specialist.
Pardon me. It's nice to see you both today, and I'm really excited to be able to speak on behalf of men as part of the Drive for Men's Health. I'm Andrew Mendenhall. I'm an addiction medicine specialist, and I'm a medical director of an outpatient clinic here in Beaverton, Oregon, as part of the Hazelden Betty Ford Foundation. I wanted to start off, since you guys are driving, with a metaphor that comes from the old rock and roller Henry Rollins. And he was a member of Black Flag back in the 1980s, among a couple of other bands. And I saw him present a few years back, and he said, you know, our bodies are like high-performance sports cars. And in reference to drugs and alcohol, he says, why would we pour sugar in the gas tank? Why would we pour sugar in the gas tank of our bodies and our minds? And I think that's a great segue into a brief segment on alcohol. And it's important to recognize that alcohol is the most widely used and abused drug among men on a worldwide basis, and that's what makes us relevant to discuss. It's important to remember that most people who drink alcohol don't become alcoholic, but many men will suffer the negative consequences of drinking too much. And when we compare men and women, men binge drink 6 times more frequently than women. And on average, the average man binge drinks, and by that I mean they consume more than 5 drinks, defined as a 12-ounce beer or a 5-ounce glass of wine or 1 ounce of distilled spirits in one drinking episode. So 5 or more drinks in one drinking episode constitutes a binge. And men, on average, binge about 12.5 times per year. So that's almost about once a month. And recognizing that 25% of men don't drink at all, that number among people who do drink is probably considerably higher, closer to 15 or 16 times in a year. If we consider the American Heart Association recommendations for the maximum healthy consumption of alcohol, the maximum healthy consumption of alcohol is between 1 and 2 drinks per week. So 14 drinks per week total, and not more than 1 to 2 in a 24-hour period of time. There is some consideration for weight. I'm kind of a small guy, I weigh about 150 pounds. And so for a smaller person who, shall we say, is maybe a little bit closer to the average body weight of a woman, there's some evidence that would suggest that less is more, by all means, when it comes to considering the health effects of alcohol over the long term. About 17% of men, 1 in 6 men, will meet criteria for alcohol dependency, meaning the brain has become so deeply attached to alcohol that people need help with changing their drinking behavior. And that's important to consider in terms of the lifetime of a man. And when we consider that men are far more likely to suffer from alcohol-related consequences, whether that's physical health issues, mental health issues, than women, this is an important component of men's health. I want to end with the concept that men binge more, they have more emotional, behavior, and physical consequences as a result of alcohol consumption, and it's important to remember that this affects mood, this affects performance at work, this potentially affects relationships, and when we consider your guys' subspecialty, we have to consider that alcohol suppresses testosterone production, which can dramatically affect reproductive and sexual health. With that, I'm going to conclude, and I really appreciate the opportunity to speak and support you guys on the Drive for Men's Health, and I'm open for questions.
Thank you so much, Dr. Mendenhall. That was great. It was a little different. We've been hearing a lot about urology, and it was good to hear about something different, which is behavioral health and addiction. What are some, other than alcohol, what addictions that men are prone to, and what are some preventative measures that you can let us, that men out there that are watching this know, to kind of help them either avoid the problem they're already, avoid the potential problem, or to try to help them get rid of the addiction that they are part of?
That's a great question. I think fundamentally we have to consider that the risk is ubiquitous in both men and women, and if we look at what's most common, and becoming a national epidemic. We have to recognize that the biggest issue at present is really addiction and dependency to prescription medication. If we look at the fact that more and more people are becoming deeply physiologically dependent on prescription opioid pain medications, and less commonly tranquilizers, we have to recognize that the healthcare delivery system is oftentimes the gateway into these behavioral problems. While not as common as marijuana, marijuana is second to alcohol in terms of the most commonly abused drug. We're starting to see significant upward ticks in terms of dependency on marijuana based on increases in potency, increases in access, and the changes of marijuana policy. Fundamentally, I like to tell guys, in particular, if you're using a little bit more than you should, whether it's alcohol or marijuana, that's an indication that the brain is becoming attached. And I think what most guys tend to do is they tend to minimize the impact. They tend to minimize the attachment that's happening. And a guy that's out there working hard day in and day out starts to look forward to that reward at the end of the day. And whether that's a couple of beers or a couple of mixed drinks, whether that's smoking a joint at the end of the day, whether that's for a man who has chronic pain issues, maybe taking a little bit more medicine than he's been prescribed, we have to recognize that these behaviors oftentimes start out more subtly, and then they really become problems when a spouse or a girlfriend or a family member starts to talk about things. Then we know that a problem has really started. I'm not sure if you guys are still receiving me, but fundamentally, I really appreciate the opportunity to speak on behalf of the Drive for Men's Health and the Hazelden Betty Ford Foundation as part of this podcast opportunity.
Andy,
I'm back with you.
hey Andy, you still there?
I am Dr. Brahmabat.
Sorry about that. We're back on.
You see me?
Yeah, I can see you. I can see you. I can see you. I can hear you. It's just the road. We're driving on the road, so it can get kind of patchy. But I just wanted to say thank you so
Great.
much for taking the time to talk to us today, and we look forward to communicating with you, on social media, and hopefully next year when we drive from New York to California. But thank you so much. This was a very important topic about alcoholism, addiction, marijuana, and we look forward to talking more about various men's health issues as we go on here. Thank you so much. Hold on.
Hey, Andy. Hey, thank you.
You're very welcome. Take care, guys. Safe drive.
Hey, Andy. Thank you so much.
You're welcome. Do take care, Caesar.
And and thank you for your support. Really appreciate it. So hope we can keep growing this every year and keep it going strong. So thank you so much.
You're very welcome. Do take care. Be well. Safe drive, guys.
Thank you. Bye-bye.
Bye-bye.
Bye-bye. It's awesome, right? We're getting people from all over the country. It's like so cool. Miami, to like Oregon, right?
Yeah, that was great. That was Dr. Mendenhall. Let's give a round of
music.
Okay, guys, so we're having a little bit of a lull here in energy, so we're going to pick it up here. You need some caffeine.
Some caffeine. Starbucks.
Starbucks. Maybe they'll sponsor us next year. Hey, does this car have like massage?
No, it doesn't. It's not like the Jaguar was.
No.
Ready?
Okay. It's live, dude.
Oh, it is live? Okay.
Yeah.
All right, okay. Awesome. It's time.
All right.
It's that time of the day. We need some pump me up music.
I used to bite my tongue and hold my breath, scared to run the boat and make a mess. So I said quietly, agreed politely. I guess that I forgot I had a choice. I let you push me past the breaking point. I stood for nothing, so I fell for everything. You held me down, but I
I think Dr. Trost likes this song too, right? We can ask him.
Ready? What's up, Dr. Trost, world surgeon. Seconds. Oh, no, man, I want to make you look good. I want to tell you she broke up with you. So,
Once we get Dr. Trost on, there is a cool story about it.
while we're waiting for Dr. Trost, I'm going to tell you, you're cracking me up. Love the Katy Perry. I'm cleaning my desk to the music. Hey, bro, you guys are
Hope something just came up.
Trost, is it working, bro?
It looks like it. I'll hang up with you on the phone here.
the house! Woo!
Dr. Trost!
All right, I'm going to change over your screen here so you can see the PowerPoint because I think I'm behind on things. Is that right?
Dr. Trost! Dr. Trost! Okay, I told you Dr. Trost. Dr. Trost works at the Mayo Clinic. Dr. Trost actually came and hung out with us for a few months, and I think we lost him. Aren't we supposed to be the ones with bad connection, not him?
I know.
Doesn't he work at the Mayo Clinic? Don't they have everything?
I know. What happened there? Uh-oh. Should we call him?
No, he's coming back. Hey, Landon!
Yeah.
I was just gonna say, you work at Mayo Clinic, man. We're supposed to be ones with internet problems, not you.
Yeah, I tell you, I don't know. It's something's not connecting, that's for sure. But hopefully it'll be up and running now.
So Dr. Trost is at the Mayo Clinic and in Rochester, and he's going to be talking to us today about Peyronie's disease.
Peyronie's disease.
And a very, very exciting topic. So Dr. Trost, I hand the web podium to you.
All right, sounds good. I'm going to do a screen share if that works out okay for you.
Yeah. It's not our internet. It's not our internet, guys. Guys, we're on the road here.
We're waiting.
We're waiting.
You know, it keeps dropping whenever I try this screen share.
Oh, really?
Yeah, let me try one more time, and then if it fails, we'll just go ahead.
God saying they don't want to see pictures of Peyronie's disease on YouTube.
Wait, I think we can see something.
Well, guys, I want to give a shout out to, here we go, Landon. Landon, you can just give your talk if you don't want to share your slides. It seems like it's too hot for YouTube. Google is blocking you.
Well, it may be. I'm not sure. We've gotten clearance on that. It keeps having an error anytime. So I'll just go ahead with the slides as far as reading off.
Is that your office?
Yeah, I haven't decorated it yet. Just been a little too busy to go through. So at some point, my wife's going to put a plant in here.
Well, where's the picture of us three together?
Oh, I think it's under the table somewhere down here. I don't remember. Something like that.
All right, buddy. Go ahead, man. Thank you.
Oh. Well, and I'll just kind of go through some of the basics of Peyronie's disease. And today, specifically, as far as the drive for men's health, this is one topic that is clearly something that impacts quite a few men in general. And so I'm just going to cheat off the slides behind me. But when you think of Peyronie's disease, it's actually a condition that not a lot of men know anything about. It's characterized usually by a couple factors, one being penile curvature, another penile pain, as well as what we call a palpable plaque, or an area of scar tissue in the penis itself. There are other things that it's associated with, including decreased penile length. It can also be erectile dysfunction. And really only about 10% of men notice any preceding trauma. Now that's a classic sign that's usually described with Peyronie's disease as trauma, but it really is a rarity. It's predominantly a Caucasian illness, really, about 8.5-fold more likely to happen in Caucasian males as opposed to other races and ethnicities. And what is interesting is when we do screenings of populations, so men who come in for PSA screening or things like that, about half of them don't even know they have the disease. So we just find it on the exam itself. So again, it is pretty common there. Now it's an older disease. It's been around for roughly about 5,000 years that we know of. It got its name from a gentleman by the name of François Gigot de la Peyronie, and he was the physician to King Louis XV, and that's where the moniker comes from on there. Now, one question a lot of men have is, does the fact that I have Peyronie's disease, does that mean I'm going to have some other major condition? And with Peyronie's disease, we definitely don't see it leading to things like cancer. It's not associated with heart attacks or strokes or some of these other major factors that people worry about. But it is associated with a significant amount of psychological distress. Men with Peyronie's disease, for example, they're more likely to have things like depression. Can be in upwards of 50% of men will have depression. And the best equivalent that I can think to compare it to is breast cancer in women. So men with Peyronie's disease, for example, or say women who lose their breasts, it's not necessarily a functional unit for them, but it definitely associates with how they see themselves, the female aspect of their character, and men are the same way with Peyronie's disease. Can have a major impact on how they view themselves, their masculinity, and so on with it. Well, how common is it? The estimates vary quite widely. It can be anywhere from 0.5% all the way up to 13% as far as the general population. And then when you have specific subgroups, so men who've undergone a prostatectomy, those with diabetes and erectile dysfunction, it can be even upwards of 20+%. So it's much more common than you see. We do see a lot of men self-diagnosing with it thanks to the internet, where they can go on and put in penile curvature and they get an idea and come in with a diagnosis, so we do see that much more often. As far as evaluation is concerned, a lot of men wonder, well, if I come into my doctor, what's he going to do? And the first part of that is really just get a very detailed history about the condition. When did it originate? How long has it been going on? How severe does it impact your ability to penetrate? If you have, say, 10 degrees curvature, it's nothing in severity compared to the men who have like 180 degrees curvature as far as your ability to penetrate. Now that said, even slighter curvatures can still have a major impact on quality of life. We'll want to know any prior treatments you've had, any medications you've been on, if you have any pain either with yourself with erections or with a partner, if your partner's having pain. And finally, on exam, we're going to go through things as far as looking for a palpable penile plaque. We're going to try to see if you have anything called Dupuytren's disease. It's a scarring of the hand that occurs. And we'll do a very thorough and complete genitourinary evaluation. Another aspect that we usually do obtain in men with Peyronie's disease is a penile ultrasound. I had some pictures to be able to show you kind of what to expect with that, but usually consists of a medicine that's injected directly into the penis that results in an erection. From there, we put an ultrasound on the penis to measure blood flow going into the penis, blood flow that may or may not be leaking out. It also gives us a very good chance to really assess the curvature. We're trying to see not only the extent of curvature, but any hourglass deformities, narrowing, things like that. So it gives us a very good objective assessment of the penis itself. Options. So just briefly, it's a very long discussion, but we'll just narrow it down real briefly. There's different categories of treatments you can consider. The first is pills, and those are probably the most highly studied, most commonly discussed on the internet as well. And the very short answer on pills is they really don't work, at least consistently. There aren't consistent high-level studies, so randomized placebo-controlled trials showing benefits of medications. And the few that there are have either often been discredited or being withdrawn from the literature in certain cases too. So in general, pills, we don't recommend them highly for treatment of it. Now, topical therapy, some people have tried topical steroids or topical verapamil, for example. And topical alone does not appear to have much of a benefit. But when you combine topical with things such as ionophoresis, there are different methods that will help to infuse the medication deeper. We do see a benefit in select groups in that case. Now, probably the most common non-surgical treatment that has shown benefit is intralesional injections. And there's several different treatments, including verapamil, interferon, and now newly FDA-approved Xiaflex, which has shown benefit here. Now, some of them have shown benefits on randomized controlled trials, others haven't. But really the best among the three medicines right now that we believe is Xiaflex. It's a bacterial enzyme which has been extracted and has been concentrated and synthesized that breaks down the plaque itself with Peyronie's disease. The medicine does have a clear benefit. There's no question that it does work. On average, though, when you look at the trials, you can get about a 17-degree improvement. So that always has to be taken into consideration, that if you're not going to be happy with a relatively minor improvement, then that may not be the best optimal choice for you. Now, on the other hand, some men did experience significant improvements, even upwards of 70+% improvement in their curvature. But just to know, on average, you're looking about a 17-degree improvement. And finally, surgery does have a role. In men that have more severe curvatures or those who have terrible erectile function, surgery typically is going to be one of the mainstays of treatment. In general, if you have terrible erectile function with a curvature, we'll go with a penile prosthesis that will straighten the penis as well as restore the ability to achieve a rigid erection. Alternatively, we can do either a penile plication, which is essentially stitches put in the opposite end of curvature that straightens the penis, or we can do an incision and grafting procedure where we'll cut into the plaque itself, straighten the penis, and then put a graft in to make up the defect. These, of course, have side effects. Any surgery, you have the possibility of worsening erectile function, decreased penile sensation, changes in perceived or actual penile length. So there's something that we definitely select and recommend on a case-by-case basis. Finally, when should you see your doctor? If you notice a new onset of penile curvature or a new plaque, if you're unable to penetrate or you have worsening or associated erectile dysfunction with a curvature, then that's really the time to see it. Most of us like to see someone early in their disease process as opposed to later in the hopes that we can help stem some of the progression of it. And with that, I thank you very much for your time and to be able to participate and welcome any questions or discussion you may have. And Jamin and Cedro, I don't know if you're still there or if you can hear me. I see you looking at the camera. Well, if you're still there and you have any questions...
Lennon, that was
go ahead.
Very good. That was very...
You still there, Jamin? I think we're cutting out.
Cedro? Yeah, that's good, Landon. I think we're in a really bad patch, but thank you so much. You know, say them to you, but this was awesome, Landon. Thank you very much.
Oh, anytime. Glad to be able to participate. Good luck. Good luck with your power nap later on. Well, we'll see you later. All right, take care, guys. Take care.
So like in Jackson, the person who's in charge, we're going to give him some as well on our website, things like that. You know, there's ways we can help them out, and we're more than glad to promote them. You know, I think it'd be a win. No, we did. Yeah. No, we've done what. Yeah, we've done what. Yeah, like one or two places like Rocky Mountain, the head guy is like working with us, so we have no problem. Some of the other smaller ones, we reached out to them, but it's like we have approvals from around people, and that's about it. So what we're is contact information. So he's on our list and stuff. But if there's any way you could give us, because if you guys don't help us, I mean, there's no way that we can pull something up, And yours are charging stations. I mean, so this event is really aimed at trying to promote and make you guys look good too. So you've got to help us out. I mean, this is really unfair not to give us the. Yeah, and I think when no, it wasn't. No, but the thing is, like, and I think that's, it's